Hi guys, welcome back. We shall now be talking about epilepsy and EEG. First, I would like to focus regarding aspects related to EEG that will help us solve image-based questions that come on this topic. The person who's credited with inventing EEG, his name is Hans Berger. Just like Eithman was the one who was responsible for ECG, Hans Berger is for EEG, and the system that he developed, the 1020 electrode placement system, it's called as 1020. That's the international norm for it. 1020 system for putting electrodes on the scalp of the patient, and the same system is very much in vogue even at the moment. You will notice that when they put these electrodes, the ones which are in the central part, they're all having the nomenclature Z, whereas the ones on the left hand side will always be having the odd number. So you need to remember that electrodes on the left side, they will be having odd number, electrodes on the right side will be having an even number. Why? Because when they give you an image based question, you will notice the fact that superiorly most of the time, by nomenclature also, and usually most of the time, the left side of the brain will be represented in the upper part of the EEG, and the odd number, which is left side, versus even number, that is the right side, can be easily identified by you. Then as you scan horizontally from left to right on the x-axis, you might see abnormal discharges. At the moment, you can notice that the abnormal discharges, which are relatively high voltage as compared to the background discharge, are being present on both left and right side of the brain. So this means it is a diffuse discharge. This goes in favor of generalized abnormality in a patient. On the other hand, suppose the abnormal discharges were shown only in one lead, that is suppose left side, or maybe on the right hand side, then we will call it a focal seizure. So in the classification, when we read the word focal seizure, that means the abnormal electrical activity is utilizing circuit in, let me say, right side of the brain, in the motor area 4 of the brain. That's where the representation of each and every muscles in the body is there. So if in area 4, if the electrical activity is in the right hand area, then the electrical activity in the right hand will cause abnormal movements on the left hand side. So person will start having focal seizure, and usually the area of the face is close to the area of the hand. So most of the time you will notice that in focal seizures, if person is having a right-sided abnormal electrical activity, then he will be having involuntary jerks on the left side, and they will be twitching or contraction the muscles also on one side of the face. So focal seizures on EEG can be identified. Why? Because you can see the abnormal electrical activity on only one side, that is either left or the right side, as the case may be. But in generalized variety, bilateral abnormal activities can be seen. So it's fairly straightforward to pick up, because the images that they're giving you are very classical from Harrison, as I've shown here before you. And to be more confident about this, we will also look at some background rhythms that one should be aware of. So let's look at the normal brain electrical activity for you and me. First of all, you should be remembering these values that I am going to mention before you. Like suppose I ask you that please close your eyes. So if your eyes are closed and you are mentally relaxed, then the discharge of yours will be called as alpha, as shown here, and the discharge frequency will be in the range of about 8 to 13 hertz. What I mean by 8 to 13 hertz is that in 1 second interval, if I zoom into this, I will be able to count something in the range of about 8 to 13 waves. Now, obviously, this is going fast, but I'm saying that if I slow it down, then I'll be able to count 8 to 13 waves when your eyes are closed. At the moment you are awake, you are listening to me when you are alert. So when a person becomes alert, when eye opening is present, then we shift to what is called as beta rhythm. This is a faster discharge frequency between 13 to 30 hertz. So most of the time when we start recording the EEG, we first tell the patient close your eyes, we get alpha. Then we say open your eyes, we get a beta. So we can see the normal brain activity, and then interspersed in that background rhythm, there could be abnormalities also when you record the EEG for relatively longer duration. Lots of time it's a possibility that when you are recording the EEG, the interictal period, meaning of the word interictal period is that there is 2 episodes that have occurred. In between that, lots of time EEG might be normal also. Like for example, in focal seizures, majority of the time EEG turns out to be normal. I mean, a person who's having focal seizures, lots of time, he might come to you and say, sir, my EEG is normal most of the time. Because focal seizures usually occur in conditions like neurocystic psychosis or mesial temporal lobe sclerosis. There are some focalized areas in the brain which are having fibrosis and associated electrical abnormality, so their EEG can be normal in between the discharges also. So that is why I was saying that if you record EEG for 24 hours or longer duration, that is video EEG recording is superior to the recording that we do on a paper, because we can monitor the patient for relatively longer durations. Now as we go into sleep, our brain rhythm tends to become relatively slow, and we go into what is called as a theta rhythm. In theta rhythm, the discharge frequency will become relatively slower. As you can see that the amplitude has become slightly much more than what it was initially, and the frequency has become relatively slower. So 4 to 7 hertz is the discharge frequency for theta that you need to remember, and amplitude is slightly increased. As we drift into more deeper sleep of NREM phase, because first when we go into sleep we are NREM, then we go into REM phase. If a person goes into REM phase directly, that is what is called as narcolepsy. That's a separate aspect. But first we go into NREM, then we go into REM. So a person will go into the second stage, that is second stage of NREM 2, which MCQ wise is the longest phase of NREM, as you know from physiology. So there you will be having sleep spindles, which are also called as mu waves. The discharge frequency at this point of time can be slightly higher. It can be between 12 to 14 hertz, and you can see a marked increase in the amplitude as we are sleeping. And as we drift into the deepest part of the sleep, the deepest part of the sleep for you and me is NREM stage 3, when we get delta wave. So in the exam they have asked that which EEG wave will be having max amplitude. Your answer would be given as delta waves. And they also have the slowest amplitude. The amplitude of the delta waves is 0.5 to 4 hertz. That is, in 1 second period, there will be only 0.5 to 4 waves only present. So you can see max amplitude, and the slowest EEG pattern is delta waves. That is the deepest part of the sleep of ours. I mean, this part of the sleep a person is most difficult to arouse. And as we go into REM phase, then the tone of the muscles will become significantly reduced. It might so have happened in your life that you had a bad dream. You might be able to even recall the bad dream, but you will feel as if your body is paralyzed. You will not be able to react to that situation, the bad dream that you are having. So that is REM phase, where our tone of our body is the least. In REM phase, however, the EEG waves have a very peculiar pattern that you can see, which is referred to as a sawtooth pattern. So let's have a quick recap of the waves that you need to remember. First is standard alpha beta, which is, you know from physiology also. If eyes are closed, alpha 8 to 13. If beta awake, like you're listening to me at the moment, you are going on beta and even faster. NREM phase is when you're starting to feel drowsy and you are tending to fall asleep. That is when the theta waves would come and the discharge frequency 4 to 7 hertz. It might even happen to you that in NREM 1, when you are feeling asleep, suddenly you might feel as if you are falling. Listen to me carefully. You are feeling very, very, very sleepy after, let me say, doing lot of exercise or lot of work in the hospital, and then you had to attended a lecture of 1 hour, 2 hour on your mobile phone. Now you're feeling very sleepy. So in NREM 1, there might be a possibility that suddenly you might feel as if you are falling. That presentation that I said, that suddenly your leg will jerk, is called as myoclonus. So myoclonus can be physiological also. I will talk about myoclonic epilepsy today with you, but myoclonus can be physiological also and can be present in NREM stage 1 when a person is drifting into sleep, that is 4 to 7 hertz. Once you go into NREM 2, you could be having sleep spindles or mu waves, and then we reach the deepest part of the sleep, that is N3 or NREM stage 3, where the EEG waves are slowest and have the max amplitude, and then REM phase will be having a sawtooth pattern. The advantage of studying all this background rhythm is that we can understand the subsequent abnormalities. So let us now try to understand what do you mean by the word seizure and what do you mean by the word epilepsy. You see, our objective is to understand the difference between the meaning of the word seizure versus convulsion versus epilepsy. Seizure would mean that the patient is having an abnormal focus in the brain, which is producing abnormal electrical discharge. The electrical discharge can be demonstrated by doing a EEG in the patient. The motor manifestation of this is called as a convulsion. You see, when you give diazepam to a patient, lorazepam to a patient, you will control the convulsion part. To suppress the abnormal electrical activity, you have to give lamotrigine, levetiracetam, or older drugs like phenytoin or phenobarbital to the patient. You will understand this better if I give you a description of GTCS patient, generalized tonic-clonic seizures. This is a healthy individual. He's never had an episode like this earlier. He says, when I woke up in the morning, I was just not feeling right. There will be no specific description given by the patient of his symptoms. He will just say, I was not feeling well. This is referred as premonitory symptoms on the part of the patient. This is not aura. I'll describe aura to you subsequently, but MCQ, as remember, aura word is written in MCQ focal seizure. In GTCS, he will always see premonitory symptoms in a patient, which means a general unwellness on the part of the patient. And now the history will be subsequently given by the office colleague of this guy who was standing next to him. Like these guys were two guys were chatting at the bus stop, and they were discussing cricket match that had occurred yesterday. They were talking about Virat Kohli, etc. And suddenly his this gentleman who's having these premonitory symptoms, he lost consciousness, and there was uprolling of the eyeballs of the patient, or maybe he even fell on the ground immediately. During tonus, what we usually find is that the person becomes unresponsive and there's a sudden contraction of all muscles in the body, but he will not be able to maintain his posture, so the person might fall down or slump onto one side with uprolling of the eyeballs. Due to sudden contraction of the muscles of expiration as well as of the vocal cords, there might be a loud sound produced by this patient initially. This would be called as ictal cry. To explain this, I can say, like, if somebody is feeling very sad or somebody feels like crying, when crying starts, the loud noise that is produced, right? Similar kind of sound would be produced here. The contraction of the muscles of expiration, the vocal cord would be contributing to this. The person is not in his senses. His friend is calling out to him, "What happened, buddy? What are you doing, or how are you behaving?" Because the friend doesn't know how to react, and the person will be having uprolling of the eyeballs at this point of time. They will be pooling of secretions in the mouth because the person will not be able to swallow his saliva. The tongue will fall backwards and will obstruct the airway. In some cases, during the tonus stage, the person might clench his teeth very tightly. So the tongue might come between the teeth and there might be tongue bite, which will cause even blood to appear on the corners of the mouth, which will obviously scare his non-medical friend. You will notice at this point of time, the patient will be having perioral cyanosis, deathly blue color around the lips is what his friend will say. He will say, "Sir, I thought that he will die because there was so much of blueness around the lips. He thought that he has died." However, when he checked his pulse, he could still feel a pulse, because in these patients, due to sympathomimetic stimulation, heart rate will be more, BP will be more, pupils will be grossly dilated in the patient, that is batriasis. The tonus phase lasts only for 10 to 20 seconds and then is replaced by clonus. When clonus will occur, the comments of his friend will be that I was trying to hold his body very tightly, but he was having this violent jerking. In GTCS, generalized toning, both upper limb, lower limb, and truncal muscles, there would be violent jerking of all the limbs as well as of the truncal musculature. At this point of time, if you are, as a doctor, observing the patient on the road, he's having a clonus. Even if you try to restrain the patient tightly, however physically strong you are, even if you hold the patient very tightly, you will not be able to control the clonus. In fact, the guidelines are not to try to restrain the patient, because that results in soft tissue injuries. You will hold him very tightly. They could be ligament tear, they could be shoulder dislocation possibly occurring in a patient. So, in fact, they've given a question on this aspect that an epileptic is having a convulsion on a railway platform. What would he do? Your answer would be wait for the convulsion to get over and transfer to the hospital. Because when he's having this violent shaking, even if you try to turn him to one side, his position cannot be maintained because of the violent shaking. So there is no point of trying to secure the airway right on the road. You have to wait for convulsion to get over and transfer to the hospital. However, if clonus is occurring in the premises of the hospital, right in front of you, a patient on the stretcher is having that violent shaking, and there's uprolling of eyeballs, frothing from the corners of the mouth, sinus is present, I will not wait for the convulsion to get over or these manifestations to get over. I will straight away secure an IV line and I will give diazepam, lorazepam to the patient. So diazepam, lorazepam suppresses this violent jerking. But to suppress that abnormal electrical discharge, I need to give levetiracetam, lamotrigine, depending on the case. Maybe most of the time in GTCS like this, we are using either valproate or we are using lamotrigine for the patient. The total duration of tonus and clonus combined is, in most of the cases, less than 60 seconds. Though we can have GCSE, that is generalized convulsive status epilepticus, where the manifestations can continue for as long as 5 minutes. The cutoff for GCSE is not 30 minutes. The cutoff for generalized convulsive status epilepticus is 5 minutes. But most of the time in GTCS, I said two terms, right? One is GTCS, second is GCSE, generalized convulsive status epilepticus. The definition of generalized convulsive status epilepticus is convulsions lasting for duration more than 5 minutes. In GTCS, most of the time, both tonus and clonus are over in 60 seconds, but then the person will not awaken and open his eyes and start talking to you. The patient will be unconscious. He will be unresponsive to commands like what is your name, where do you live, what is your cell phone number. At this point of time, there's a possibility that Babinski sign might be elicited in the patient, in this unconscious patient. Corneal reflexes may be absent. But once he will regain consciousness, then corneal reflexes will come back and Babinski sign will disappear in the patient. So I'm calling it a deficit because neurological findings are being found in the patient. Even when he will wake up, he will not immediately be okay. He might appear dazed, confused. He might be looking here and there. He is not realizing in the hospital. After a few minutes, he's gradually realizing that, oh, I am in a hospital. There's a doctor nearby. He might say, sir, can I borrow your cell phone? Can I call up my relatives? I was at the bus stop. Who brought me here? Where is my friend? So gradually the orientation of this person to time, space and person will start occurring. So these manifestations that I've explained to you are the usual profile that you will encounter in your patients of generalized tonic-clonic seizures. The investigational choice for generalized tonic-clonic seizure would be answered as EEG. The drug of choice is sodium valproate, that you know from pharmacology. But I basically wanted to explain to you how the manifestations will occur in a patient. On basis of this explanation, I have tried to explain that technical meaning of the word seizure would be abnormal electrical activity in the brain, whereas the motor manifestation of the same that is occurring in the patient is called as a convulsion. So the question arises, what is epilepsy? Meaning of the word epilepsy would be that patient will be having recurrence of these episodes that I have here represented before you. The technical meaning of the word epilepsy would be that if a person is having at least 2 or more than 2 unprovoked seizures. What I mean by unprovoked is that suppose a person is having, let me say somebody is a diabetic, right, and he's having hypoglycemia due to insulin overdosage, then insulin overdosage is a trigger. So here meaning of the word epilepsy is it should be unprovoked seizure in a patient, because hypoglycemia is a provoked seizure, head injury is a provoked seizure, cerebrovascular accident is a provoked seizure. I am saying meaning of the word epilepsy is at least 2 or more than 2 unprovoked seizure episodes documented in a patient. To terminate this convulsion part, the drug that I will be using would be lorazepam. I will have to secure an IV line, which is a little difficult. If I cannot get IV access to control this convulsion part, I might even be forced to use rectal diazepam. So to understand things better, next I will be explaining to you regarding the classification that is currently being used to identify or subclassify patients with seizures. The basic terms that are used are focal seizures, generalized seizures, though there's a possibility that sometimes patients with focal seizures can be having a evolution into a GTCS. Earlier, the term used was secondary generalization, but now they say focal seizure with evolution into generalized variety. And third, well, it's not important MCQ wise, but still I have to mention it, that is of unknown onset. Starting with the left hand side, focal seizures. Earlier, when I was at your age, I used to read words like simple partial seizure, complex partial seizure. Now they have tried to simplify things by saying that if a person is having a focal seizure, that means that there is involuntary movement, suppose in the right hand of the patient, which means that there is a abnormal electrical activity in the left motor area, and this particular patient could be having a possibility of intact awareness, that is, person will himself describe the symptoms. However, there is also a possibility that the person might lose consciousness. Like this person, he started having these jerky movements, he lost consciousness, and his office colleague was saying that, sir, he suddenly lost consciousness, he slumped on the office table, like they were having coffee together, 2 people, and he says he slumped on the table and there was involuntary movement in one arm of the patient and maybe same side of the face. So because the hand area and the face area and the motor cortex are close together, so you could be having coexistent involuntary movements. That would be called as the first one I said is intact awareness. So the second one will be called as, because he lost consciousness, it will be called as with impaired consciousness or impaired awareness. So instead of using the words SPS, simple and complex partial seizure, that's a much more easier way to understand it. Now, not all patients will be having motor manifestations. You know, some patients could be only having pin and needle sensation in right arm, or there's a possibility that he might say that I could smell burning rubber, or I could smell burning kerosene, or I could smell rotten fish. So some patients can be having non-motor manifestations also, and one possibility is that the person is describing everything when he came to the hospital. He says, okay, this is what happened to me. Second is he became unconscious, and later on he says that I was having this pain sensation in my arm, and then I was also having this weird sensation of bad smell. Or for some people, even visual aspects can be there, like brilliant flashes of light. Or you might say that everything started becoming smaller, that is micropsia. Everything started becoming bigger, that is macropsia, and then he lost consciousness. So that is why they use terms like with intact awareness, with impaired awareness, motor, non-motor manifestations in a patient. And lastly, as I said, there is a possibility that person of focus with will show a evolution into generalized tonic-clonic seizure. Now, why it is important for you to know this classification? Like, for example, I spoke about this evolution into GTCS. This is because the drug of choice for focal seizures is different for as compared to drug that we use in generalized tonic-clonic seizure. Like in focal seizure, if a person is young, we usually use carbamazepine, but in very old age patient, we use levetiracetam. I will discuss the treatment of focal seizure subsequently with you, but what I'm telling you is that a person with focal seizure, we use drugs which are slightly different from, like carbamazepine I was saying is used for focal, and for generalized we are using valproate or lamotrigine or levetiracetam for the patient. So drugs used are different. So because the drugs used are different, it is important for you to identify the two. And suppose a person is having focal evolving into GTCS, then it is all the way more important. Now it is very difficult. I mean, the most difficult case for you in the topic of seizure will be focal evolving into GTCS, because relatives will mainly focus on, the violent jerking of the whole body. So they will tell you everything about GTCS. They won't talk about the focal manifestation, that initially the involuntary movement was in one hand, then it evolved into the whole manifestation. So how would you differentiate? The clinical hint is that focal seizures are always associated with aura. Aura basically means a subjective sensation that only the person can feel. Like I said, he's saying that everything is becoming smaller in size, everything is becoming relatively bigger in size, or he can smell burning kerosene rubber, like I gave example. So things are being perceived by the patient. Not anybody else cannot see or smell similar kind of manifestations. So if aura is present, it is a focal seizure. And even if it is a focal with secondary generalization as a formal term of focal with evolution into GTCS, then aura will be present and then it will get converted. I mean, then person will have focal, then gradually the involuntary movements will spread to the whole body of the patient and GTCS will develop. And for management of focal seizure with evolution into GTCS, the drug of choice is not carbamazepine, it is sodium valproate. I repeat my statement, for focal seizures, we commonly use carbamazepine in young people. There are alternative drugs also that I will discuss in the pharmacotherapy part, but I want to tell you or highlight this basic concept again, that for focal seizure with evolution into GTCS, the answer is not carbamazepine, it is valproate to be answered. Now, when it comes to generalized tonic-clonic seizures in a patient, the manifestations are straightforward. Most of the patients will be having motor manifestations only, so that is what they will usually ask you. However, as the classification is, I will subclassify this. Motor can be tonic-clonic. First, the body will become stiff, then there would be jerking movements. Tonus usually lasts for about 10 seconds or so, and the clonus could be like 30 to 40 seconds. So usually GTCS gets over within 1 minute only. But in that minute, if he was driving a bike, he falls down, head injury, he had a coffee or tea and he aspirates and he vomits, there could be aspiration possibility in a patient. So those are the aspects which are to be taken kept in mind. Sometimes the manifestations will be opposite. Instead of increase of tone, there is a decrease in tone. What happens in atonic is that there would be sudden loss of tone for 1 or 2 seconds only, and they would be like this. Suddenly the neck of the patient will drop. So the manifestation could be, for a non-medical person who's sitting opposite the person, he might say that there was suddenly a head nodding kind of a movement, like because he's sitting like this, he's reading a book, right? And suddenly the tone decreases. Tone can decrease with the whole body, then he will fall down. Serious injuries can be seen in a person. But if it is usually, and most of the time, I mean, the presentation is transient decrease of tone, mostly of the muscles related to like supporting the neck. So there is suddenly a head nodding movement occurring in a patient. That is usually the profile of atonic seizures in a patient. Myoclonic. How about myoclonic? Like I am sitting like this, suddenly a jerky movement of the leg. Myoclonus can be focal also, myoclonus can be generalized also. So that is one I want you to understand. Myoclonic jerks, in fact, to explain to you myoclonic better, I can give another example. Suppose you're very sleepy and you're falling asleep. If I am very sure this might have happened to you sometime. You are feeling very sleepy, and suddenly right at the peak when you are feeling very sleepy and your eyes are closed, there is a possibility that you might get a feeling as if you are falling. Please appreciate, myoclonus can be present physiologically also at the onset of NREM1. There's a possibility that you might get a feeling as if suddenly you're falling and there might be jerky movement and you might awaken for a second. It might have happened to you, sudden awakening in onset of NREM1. So myoclonus can occur in a normal person at the onset of sleep. It might suddenly jolt you out of your sleep for transiently few seconds. You got a feeling as if you're falling, then everything is back to normal, you go to sleep. But if these myoclonic jerks are occurring in awake stage also, like the person is eating his breakfast, right? He's eating his cereal, like this child, juvenile myoclonic epilepsy, mother poured cereal for the child for eating his breakfast and he's eating and suddenly jerky movement, so the breakfast spills over. So mother will think he's spilling the breakfast deliberately. He's getting late for school, the school bus is honking outside, or the auto rickshaw driver has come who's carrying the child to school. And lots of time, why I'm explaining this is because myoclonic epilepsy, lots of time the jerky movement of the hand results in difficulty in getting ready for school, because if a jerky movement, there's difficulty in putting up a button in your collar, there's a difficulty in eating your food. So most of the time in myoclonic jerks, especially in juvenile myoclonic epilepsy, the child might get late for school and parents might think that he's deliberately doing it, but those jerky movements are like continuous sudden jerk movement. Focal seizure is like this. Myoclonus is like a jerky movement, like this, stopped, then erratically in another arm. So those are tonus clonus, right? Then atonic, suddenly decrease in the neck tone and maybe a possible fall. Then myoclonic, a jerky movement causing spilling of breakfast of an individual, and non-motor manifestations. Non-motor I will explain from specially pediatrics perspective, because absence seizures are commonly found in children between 4 to 10 years of age that would be having vacant staring spells. These children would be called as daydreamers. Then we can have a atypical absence seizure also. We will have to learn the EEG difference between absence and atypical absence, and as we progress in the discussion I'll explain that to you. For unknown onset, again you could be having motor manifestations, you could be having non-motor manifestations. So this is a simple classification in the 20th edition of Harrison that he has mentioned. He's basically trying to say that don't use technical terms like, or complex terms like simple partial, complex partial seizure with dyscognitive features, without dyscognitive features like earlier, simple words, with intact awareness, with impaired awareness. So that's way we are able to understand the disease process better, and we are able to explain to our patients also relatively better. Now let's focus on the extreme left hand side of the table. I will first explain to you, this is the table of Harrison. I will now be explaining to you aspects related to mainly focal seizures. So we will now talk about each one of these individually, and I will be explaining focal seizures to you. Two important causes for focal seizures that at the moment I want you to remember is one, neurocysticercosis. Another one can be a local lesion by the name of hippocampal sclerosis. This causes temporal lobe epilepsy. This is in fact one of the surgical remediable causes of epilepsy, because normally we use medicines, but in this case the response to medicines will be poor because there's a particular lesion occurring in the brain parenchyma, so surgery has to be done. The bottom line is that focal seizures will always be utilizing a local circuit in the motor cortex if it is motor, otherwise non-motor sensory area can be involved, but there must be some lesions that would be responsible which are contributing to the manifestations. Now, most of the time, like the person might say that I am sitting in my office, he is holding his coffee and suddenly in the right hand, there is involuntary movements occurring. This means the fact that the abnormal electrical activity is occurring in the left motor cortex, and along with that right face twitching, involuntary movements will also be occurring. His office colleague is wondering what is happening to him, and he will describe everything that, I was feeling embarrassed that everybody is looking at me and this continuous involuntary movements on one side of my face is occurring. In fact, some patients would even tell you that first the involuntary movement started in my thumb and hand, so I used my other hand to grab it. But I was not able to control this jerky movement that was occurring on the right arm in spite of using the power with his left hand. And he's aware that everything like this is happening. So because he will describe features starting from the distal, then involvement of the proximal parts also. So you will read about what is called as Jacksonian march. That's one of the highlight of the motor manifestations in focal seizures. The abnormal movements start from the distal part and progress to the proximal part. The same person may not be able to use this arm now for hours and maybe days. So that manifestation would be called as Todd's palsy. Todd's palsy, when person will come to you first time, you might get the impression he's having stroke, no? Because person came to you just says, I don't have power in this arm. You thought maybe he's having stroke. Then it turned out that it was an abnormal electrical activity in the brain which is resulting in this manifestation, and gradually the power will come back. In stroke, power is never going to come back. No, if stroke manifestations will occur, he will remain like that, he might deteriorate. But at least in Todd's palsy, we would be having a definitive recovery. So weakness that would be persisting for maybe hours to days after episode of motor manifestation of focal seizure is called as Todd's palsy. In some cases, the manifestations might continue for long duration. That may be for days and weeks altogether. So the term that is used is epilepsia partialis continua. This is the counterpart of GCSE, generalized convulsive status epilepticus, where if a person is having convulsions continuously for more than 5 minutes, we call it GCSE. The corresponding component of that when it comes to focal seizures is called as epilepsia partialis continua. The manifestations in this patient can continue for days and maybe can spill over sometimes into weeks also. The non-motor manifestations of the patient can range from paresthesias to vertigo. He will say that I was feeling as if the room is spinning around my head, or he feels that he will fall. And then would be sensory manifestations coming up like sensation of burning rubber, as I've explained multiple times to you. And nobody else will be able to appreciate this. I mean, if person is telling you this, you are wondering, I mean, is he telling the truth, or is he imagining, or is he having some kind of hallucination? Here I want to tell you the temporal lobe is the one which helps us integrate the sense of smell. So the abnormal electrical activity could be originating in the temporal lobe of the patient, and that is why he is having this impaired sensation. Then if the abnormal activity is related to the occipital lobe, or the connections between the temporal and the occipital lobe, like the visual association area, then everything might become smaller to you, micropsia, or everything might become bigger for the patient, that is macropsia. This is like, you read about Alice in Wonderland syndrome. You children, you would have read this storybook, no? Alice in Wonderland. Alice falls down a rabbit hole, and then everything is very huge or everything is very small. So similarly like that, micropsia, everything is smaller, macropsia, that is relatively bigger. So Alice in Wonderland syndrome is a broad term, but Alice in Wonderland syndrome basically implies that person could be having a possibility of a temporal lobe epilepsy. So what we have learned for point number 4 is that my patient is having subjective internal events which cannot be understood by or cannot be perceived by a person sitting outside. I'll just complete the statement. Subjective internal events which cannot be observed by a trained physician. The technical term for this is called as aura. That is how you differentiate generalized seizure versus a focal with a secondary evolution, because if a person is having a focal seizure, he will always have a aura manifestation, then he will start having a GTS, whereas a plain GTS, there is no aura, there is only premonitory symptoms. So that's again an MCQ statement important for you. Aura is not a feature of answer is generalized tonic-clonic seizure. There is premonitory symptoms that are seen in generalized tonic-clonic seizures. So this slide is for focal seizures with a patient having intact awareness. I will now be explaining to you patients who will be having an impaired awareness in the next slide. To understand focal seizure with impaired awareness, I would like you not to note down anything and just look at me for a few seconds so that you can understand that better. The person will be doing like this. First, you will notice patient will be having a vacant stare, like I was just staring at you. Then he might be having lip smacking movements, or that is chewing movements, or he might be doing like this, swallowing movements again and again. It could be picking. Now if I put my hand down, you may not be able to see I'm doing on my shirt, like picking movements, like you're trying to pick up something. Or he might be having uncontrollable laughing or crying. I mean, if you are looking at this guy, you'll be wondering what happened, man. He's just staring and laughing, or maybe crying unnecessarily. This manifestation that I described before you is called as automatism. So one of the key words that you need to remember for MCQs is automatism is a feature of focal seizure with impaired awareness. It starts off with an aura, as is a classical feature of focal seizure, ranging from micropsia, macropsia, burning rubber smell, etc. Then it goes into a motionless stare. This is when a non-medico will also realize something is abnormal about this person, because maybe two chaps were talking together, like these students are talking to each other, they're living in a hostel, non-medicos, and the non-medico fellow, the friend of his, he says like, I don't know what happened, my friend was just looking at my face and then he started laughing uncontrollably and I was scared because he's laughing hysterically. So automatism can range from movements which could be like lip smacking, chewing, movements exhibited by the patient, swallowing, picking movements, and the one that will look very outrageous or very surprising to anybody would be laughter or crying. Now after the episode is over, his friend is asking him, shaking his shoulder, "Bhai, kya hua? What happened?" And this person will appear totally dazed and totally confused. So there will always be a presence of post-ictal confusion. His friend is asking him, what happened to you? Why were you laughing? Why are you crying? Why were you behaving like this? You scared me. And this guy will be like dazed, like what really happened? So there is a post-ictal confusion and his friend is asking him कि तुझे पता नहीं है तुझे क्या हुआ, तू ऐसे हंस रहा था, पागल जैसे हंस रहा था, right? His friend is asking you, you're laughing like crazy. So he will be not having any memory of the recent event. This loss of short-term memory that I'm explaining to you, this is called as antegrade amnesia. So the highlight why I'm saying impaired awareness is based on the fact that there will be a very characteristic post-ictal confusion and antegrade amnesia in this patient. In fact, in some of these patients, you might even be having transient neurological deficits, like the person might develop inability to speak for a short duration. That could be for a few minutes to a few minutes, but transient deficit in the form of aphasia can also be seen in the patient. So you can see that not all patients would be having that, either violent jerky movement of the whole body, that is GTCS, focal seizures with, I would say, preserved consciousness. Some patients could be having manifestations like these with impaired awareness also. So when I was a student your age, I used to study all of this as complex partial seizure, but now they've removed the unnecessarily terminology. But still, why I'm using it is because if they give you questions of the previous years, right? Sometimes, they can pick up a question from the previous years. They may not give you the exact latest information given in the book. So you should be familiar with the terminology. This was earlier called as complex partial. Now it's called as focal seizure with impaired awareness in a patient. If you perform EEG in these patients in the interictal period, there's a possibility that EEG can be normal. Interictal period would mean period between two episodes of seizure. So there's a possibility that EEG can be normal also. However, if you will do imaging, then lesions or neurocystic cirrhosis or hippocampal sclerosis can be picked up. Also remember that if the EEG of the same patient is done in the ictal period or when the episode has occurred, then you might be able to notice abnormal high voltage bursts noted in some of the leads. Like if you notice, you can see background activity in the left-sided leads. The left-sided leads are all odd numbered and the right-sided leads are even numbered. So in this person, only in the temporal leads are we noticing mainly abnormal electrical activity. So this EEG will be answered by you as that of focal seizures in a person. And the possible origin of the abnormal activity is from the temporal lobe. So there's a high possibility that this person could be having problems with maybe smell, taste, vision, special senses of the ones which are assimilated in the temporal lobe. So that's why those manifestations are appreciated by patients of focal seizures. We shall now be comparing this information that we've learned for focal seizures with that of generalized seizures, generalized onset of seizures. The first that I will explain to you will be typical absence seizure and compare that with atypical absence seizure. The highlight of this is that there is no tonus and no clonus. That is why the name is absence. So what do you have here is a loss of consciousness. It's a transitory loss of consciousness for only 1 to 2 seconds. However, the postural control is maintained in this patient. The postural tone is maintained in this patient. You have to appreciate this fact very clearly that if I was saying a person is having loss of consciousness and there is decrease of postural tone and person does like this, suddenly the neck of the person will flex as if he's fallen asleep or he might fall down. That is atonic seizure. But in absence seizure, though there is loss of consciousness for a few seconds, postural control is maintained in this patient. You will also notice that in these patients, before the attack will begin, patient will start doing like this. You can look at my eyes again. A repeated blinking of the eyes. So let's look at the manifestation. This is a child. He is 4 to 10 years of age. His mother is very worried about him because he does this repeated eye blinking activity. After which she says my child becomes unresponsive. She doesn't know what unconsciousness. So she says like, I'm talking to the child, I'm playing with the child, 4-5-year-old child. He came back from school, he's telling like, Mama, this happened in school, this child ate something from my lunchbox, or I had a fight with this child, and suddenly he will become quiet. And the mother is looking at him, suddenly became quiet, and she's finding him, he's having this fluttering of his eyelids, repeated blinking of the eyelids, and he's just staring at her face like this. I mean, he was talking normally. He was saying that a child ate something from my tiffin box, or I had a fight with this child, or this child took my pencil. Like small children, they come back from school and they tell whatever things that have happened in the school to the mother. So she's talking, she's interacting with the child, and suddenly the child is looking at her, he's blinking his eyes, and there is no communication that is occurring between the mother and the child, and she's wondering what really happened. So she asking him, are you fine? And then the child will start talking as if nothing has happened. So do remember that when I said the child will resume his activity as if nothing has happened. Therefore, post-ictal deficit is absent in this condition. Post-ictal deficit is always present in GTCS. Post-ictal deficit is always present in focal seizures with impaired consciousness. The person will be appearing confused and dazed. Here the child was saying, Mama, somebody ate food from my lunchbox. Then he suddenly quiet. Then he will again start talking, yeah, that child fought with me. This is what madam said. This is the homework that has come. So mother will say as if nothing has happened. There is few seconds when it is as if he is totally switched off. So varied mothers will give you different descriptions. I give you a description of a mother who came to me. She says it's like he switched off for a few seconds. That is absence of tonus, clonus, and post-ictal deficit in the patient. The mother might label the child as a daydreamer because no mother will think bad about her child. Epilepsy is like a bad word in India. So she will just say that, oh, I think my child is a daydreamer. He keeps on imagining things while talking to me. He suddenly gets lost in his own world. And then you might also get the impression, because she's being overprotective, you might think he's mentally retarded. That is why he's having this kind of a behavior. No, he's talking like she's telling you the child is talking to me, then suddenly becomes very quiet, and then he maybe starts talking to me again. So impression could be maybe a cognition defect, maybe some mental retardation component present. So because the mother is trying to be overprotected, she will defend the child and say that, oh, he's a daydreamer. Your job as a doctor is to do a EEG in this condition. The EEG of this patient will reveal a special finding that is called as 3 per second spike and slow wave pattern. Now, why and how it appears is the objective of our discussion. So let's look at, we have taken up this child in the EEG room. On the x-axis will be the time, on the y-axis would be these electrodes, that is left will be having an odd number and the even will be having a right side will be having an even number. In the electrodes of the patient, like I will first tell the child keep your eyes closed, so I will have a alpha with eyes closed. Then I will say open your eyes. The moment the child will open his eyes, the voltage will slightly become lesser and the discharge will become relatively faster, that is a beta. So first I will be generating background rhythm in the patient, that is I will ask the child to close his eyes, open his eyes. After the child has opened his eyes, I will now ask the child a question, or I will ask the child to hyperventilate, like I'll ask him to do deep breathing, hyperventilation. The moment the child will start doing hyperventilation, you will notice that after a few seconds, the EEG will suddenly become relatively slow, and you will be able to notice these peculiar waves coming in the EEG which were not present previously. Instead of hyperventilation, you can also ask your technician to switch on a bright light, switch it on and switch it off. Photic stimulation. Bright light was switched on in the EEG room, then switched off. Photic stimulation or hyperventilation can trigger an attack of absence seizure. Please appreciate, this is the only rhythm that you can generate in the EEG lab by doing specific activities like switching on a bright light for a few seconds, switch it off. Photic stimulation and hyperventilation can trigger development of absence seizure manifestations in a patient. If you zoom it in on second by second basis, you will notice that in every 1 second period now, you will be able to see only 3 waves. Each of these waves will be relatively pointed, so calling it spike, and slow because it is slower than the routine pattern. I have explained to you that the slowest EEG pattern is delta waves, that is 0.5 to 4 Hz. So because this is less than 4 Hz, so we will say this is a spike pointed and a slow wave pattern, that is highlight of absence seizure. For treatment of this condition, the drug of choice is sodium valproate. We can use ethosuximide also, especially in smaller children, because you would have read in pharmacology that valproate, if used in children less than especially 2 years of age, lower the child, lower is the age of the child, the incidence of fulminant hepatic failure can increase. Though these episodes are seen by 4 to 10 years of age, I said if the child is suppose 2 years of age, younger child, then ethosuximide can be used. And routinely, if the question does not mention the age group of the child, then the answer can be given as sodium valproate for the patient. So I will talk about the pharmacotherapy in the end also, but here I just wanted to clear this, I would say perennial question. What is the drug of choice for absence seizure? Some books say ethosuximide, some books say valproate. Well, how to solve it? I said if the age group is in the age of 2 years, 3 years, then answer it as ethosuximide. Otherwise, let it be sodium valproate for the patient. Now we will understand what is the difference between a typical absence seizure versus a atypical absence seizure. Clinically, it is very difficult to differentiate between these two generalized onset seizures, typical and atypical absence. So I'll first mention what is the main parameter, and that is EEG. This is a very characteristic term that I'm telling you, less than 2.5 Hertz. Remember my words here. Earlier I was saying 3 Hertz spike and slow wave. Now I'm saying less than 2.5 Hertz spike and slow wave pattern is a feature that helps in identification of atypical absence in a patient. In this case, usually the lapse of concentration or lapse of consciousness in a patient would be of a relatively longer duration. Like in absence seizure, it might be only for 1 to 2 seconds, here might be for 10 to 15 seconds. So most of the time you will notice that this is going to be relatively more severe and is associated with mental retardation. It could be associated with syndromes also, like I will teach you a syndrome by the name of Lennox-Gastaut syndrome as we progress in the discussion, that is usually associated with atypical absence. So 4 points to be remembered, with the most important being the first one, less than 2.5 Hertz spike and slow wave pattern. Lapse of consciousness duration wise is more. Now that is very subjective, whether I say lapse of consciousness or loss of consciousness for 1 to 2 seconds. Again, in this condition also the child will not fall. Posture is always maintained in absence seizure, but posture is always lost, or ability to control posture is always lost in tonic seizure, so person will always fall. Typical and atypical absence seizure are usually differentiated on the basis of EEG. Atypical is more common with syndromes like Lennox-Gastaut syndrome. Third, we will compare this now with what I was saying as atonic seizure all the way. Chances of injuries are higher in atonic seizure because the person can fall suddenly. The textbook will say the word loss of postural control. In the previous one, I was highlighting postural control is maintained. It is consciousness that is impaired in the patient. Here, there is loss of postural control for 1 to 2 seconds as well as loss of consciousness for the same duration. That is why injuries can be substantial in these patients. Thankfully, in most of the patients, however, the tone is not decreased in the whole body, but mostly in the muscles related to the neck. So therefore, he will say sudden onset head nodding or head dropping is a feature of atonic seizure. It is just like, you sitting and suddenly the person will look as if he's fallen asleep, then he will again be coming back. When he comes back, you will notice that he will not be having any post-ictal deficit. This is the second time in the discussion that I'm telling you that post-ictal deficit is absent. One, I said it is absent in absence seizure, then it is absent in atonic seizure. In fact, we can just draw a list here so that you are remembering it. From pediatrics, remember, post-ictal deficit is usually not found in febrile seizures. Febrile seizure themselves can be of two varieties, typical and atypical. So I'm talking about the typical variety. Post-ictal deficit is absent in absence seizure. It is absent in atonic seizure. Because a lot of things have been said, let us just summarize. If they give you a video-based question in which the whole body of the person is jerking like this, up rolling of the eyeballs, frothing the corner, GTCS, easy to pick up. Only one hand involuntary movement occurring, focal seizure. Person is conscious, is reading a book. He says this jerky movement I can control, or I am trying to control. On the other hand, if he is unconscious and only one hand is moving, that is gonna be focal seizure with impaired consciousness. Only like this, jerky movements. That is myoclonic jerks. Myoclonic can be unilateral, myoclonic jerks can be bilateral in a patient. So jerky movements that occur suddenly and can cause spilling off, like person is drinking water, suddenly jerky movements of water spills over. If it's a child, the mother will think he's doing it deliberately, like he's spilled the water. So that is myoclonic. Atonic is going to be mostly like this, sudden decrease in the tone of the patient. So there is going to be no postictal deficit in this patient subsequently, and there are three scenarios where postictal deficit is absent. So after I've demonstrated how they would look like, we can have some more theory inputs to be remembered for myoclonic seizures occurring in a patient. The description is that of jerky movements. They are sudden, they are brief, but mostly they will ask you, why does it occur? One of the important causes to be remembered is variant Creutzfeldt-Jakob disease. It would also be called as neurodegenerative disorder. This person has consumed poor quality beef, which was contaminated with prion particles. So once the prion particles get access into the brain, they enter into the neurons, they enter into the cytoplasm of the neurons, they hijack the cytoplasm of neurons and start multiplying them. So due to the irritation of the neurons, which is due to prion particles which are multiplying, there is abnormal firing of the neurons, which can cause the jerky movements in the arms and legs of the patient. The next important cause is metabolic encephalopathies. Then could be anoxic or hypoxic damage to the brain. In children, anoxic injury to the brain occurs with birth asphyxia, but in adults, anoxic cerebral injury is what we read with high altitude cerebral edema. This soldier is posted at the Siachen glacier. His condition started deteriorating because he started having swelling in the brain due to sudden ascent to high altitude, and because of this cerebral edema, he started having these myoclonic jerks in his body. They had called for helicopter evacuation, but it could not land because, let me say, the weather was very bad, and unfortunately the soldier died at high altitude. So that's the kind of stories that we hear about our soldiers dying at high altitude, like at Siachen glacier, and that is because of anoxic cerebral injury secondary to high altitude cerebral edema causes myoclonic episodes or myoclonic seizures in a patient. Most of the time, myoclonic seizures can coexist with GTCS. In fact, I'll teach a epileptic syndrome to you subsequently that is called as juvenile myoclonic epilepsy, in which in childhood person has myoclonic jerks, and when he becomes older, then he will start having generalized tonic-clonic seizure. The second last variety of generalized seizures that I'm explaining to you are called as epileptic spasms. In this case, the involvement will be mostly of the truncal musculature, and therefore the patient will literally bend forwards. What I'm talking about is salam seizures. That's the only Hindi word in medical literature. This involves mainly the truncal muscles, like the body is bent forward of the child is doubled up forward. So this is an infant. There is a salam seizure occurring in him, or epileptic spasm occurring in this patient, where the muscles involved are those of the truncal muscles. Salam is like when you bend somebody and you do salam. So similarly here in this case, two things can happen. One, the body can bend forward, and then there might be jerky movement of the arm. So it's like, you giving salute to somebody, that's a salam, and then you bending forward also. So truncal muscles and arm movements could be occurring in an epileptic spasm in a patient. The highlight of this epileptic spasm or salam seizure would be a very characteristic term in EEG that is called as hips arrhythmia. In fact, when you read this term for the first time, hips arrhythmia, it looks like a question of cardiovascular system. It looks like a question from ECG, but it is a question on EEG, hips arrhythmia. What it basically means is that the pattern that I was talking about, like I was teaching you, delta waves come when we are sleeping, alpha waves come when we are having eyes closed, beta when eyes are open. Here, there is no pattern per se. Like the person is awake and there might be a delta wave present, or there is a possibility that the child is sleeping and there might be a alpha wave present in the patient. So the normal pattern that I was explaining to you related to sleep would not be found in this condition. So chaotic pattern. This grossly chaotic pattern with different voltage, different EEG, irrespective of the stage. Like we have a very programmed fashion, eyes closed, eye open, the frequency is very fixed. In this patient, there is no such pattern. So we call it a grossly chaotic pattern, or is called as hips arrhythmia. This is itself a question. Hips arrhythmia is a feature of, answer is epileptic spasm, and he will not even tell you that hips arrhythmia in EEG is a feature of. He will just write in question, hips arrhythmia is a feature of, so you need to pick it up. And another feature in the EEG of this patient would be that the background rhythm will be suppressed. Normally, when we are sleeping, there could be REM phase of sawtooth waves or NREM various waves that I've explained. In this case, the background rhythm is suppressed. the voltage is suppressed. That is called as electrodecremental response. I hope you remember I've talked about decremental response in EMG for myasthenia gravis. I will just jot down the data for the comfort levels of yours. Decremental response in a neurology MCQ on electromyography is a feature that is seen with MG myasthenia gravis, which will have antibodies to acetylcholine receptor. But electrodecremental response in EEG of the background rhythm is found with hypsarrhythmia and epileptic spasms in the patient. For the sixth variety of generalized seizures, it is called as GTCS and has already been discussed. The highlight of this would be premonitory symptoms. Then the person will give out a loud ictal cry due to sudden contraction of the muscles of the vocal cords as well as muscles of expiration. So there would be throaty loud sound, that is ictal cry, following which there would be stiffness of the body, that is tonus, and the person will fall down. The lips of the patient might turn blue at this particular point of time because the person will be holding his breath continuously in expiration. The duration of tonus may last only for 10 seconds, but they're critical for the patient. Then there would be tongue falling backwards. There could be airway obstruction in a patient, tongue bite occurring in a patient due to tonus, due to which he may clench his teeth so tightly that the tongue might be bitten or they might be bleeding in the corners of the mouth. There would be uprolling of the eyeballs of the patient at this point, and now the patient will pass into clonus. Most of the time the relative will maybe not notice the tonus part. He might just say that the whole body was shaking uncontrollably, he fell on the ground. So there would be clonus, that is the involuntary jerking part. Even if you try to hold the patient very tightly, you will not be able to control the violent shaking of the body of the patient. In fact, you might injure the patient, as I've explained. So no touch policy is to be followed. In the premises of the hospital, control the clonus by giving diazepam or lorazepam. But outside the hospital, it is wait and watch policy for the patient. The patient will not immediately wake up. You will always have a post-ictal deficit. You will notice at this point of time that the patient will be having very, I would say, noisy breathing. That's because of the secretions in the throat of the person. So airway of this person has to be cleared at this point. At noisy breathing will be noticed. And the urine bad smell might be coming from the patient because the person towards the end of the clonus is sphincter relaxed. So urine has been passed or maybe the stool has been passed. So bad fecal smell could be present or it could be coming from the patient. Gradually there will be opening of the eyes, reorientation. These all features are encountered in generalized tonic-clonic seizure. The next point that I would like to explain to you is that a person after GTCS has become unconscious and there is another person who has become unconscious following a vasovagal syncope. Both patients have been brought in the casualty and the relatives are just telling you a history of sudden onset loss of consciousness in both of the patients. So how would you differentiate whether it is GTCS followed by a post-ictal deficit or vasovagal syncope is the objective of this particular slide. For vasovagal syncope, you will always have a trigger responsible. Like I can give a situation that a person is undergoing a dental extraction in the dental wing of your hospital and the dentist has not given proper anesthesia before doing a dental extraction. So when the tooth is pulled out and there is not adequate analgesia, due to the pain component, due to the emotional trauma component, person can become unconscious. But when it comes to GTCS, there is no trigger responsible. Like GTCS could be idiopathic also, like I have told you, epilepsy is defined as more or two unprovoked seizures in a patient. So there is an abnormal focus in the brain that will fire. So GTCS manifestations, the manifestations occur without any warning. Whereas in vasovagal syncope, there must be some warning or some trigger responsible for manifestations. Do remember the fact that tonus and clonus is found in both of these patients. The reason why you get a tonus clonus in vasovagal syncope is because of sudden onset cerebral ischemia. There's a sudden decrease of blood supply to the brain the moment the dentist pulled out the tooth. There was a lot of pain, so the person started losing consciousness, and because of decrease in the blood supply to the brain, there was tonus clonus. The duration of tonus clonus in GTCS will be between 30 to 60 seconds, but all this is very subjective because relative is not going to carry a watch with him and tell you that okay, for these many seconds this happened. So this is only for academic interest. In reality, you are not able to differentiate between the two on the basis of tonus clonus. What can help you, however, is finding a tongue bite. You see, the tongue will usually fall backwards in vasovagal syncope. So the textbook says the tongue bite is a feature that is rarely seen in vagal syncope, whereas tongue bite is more common in GTCS because the tonus part, when it happens very violently. So the tongue bite come between the teeth. Another feature that will help you is the aspect of headache. When it comes to vasovagal syncope, we do not read about headache, but GTCS is a CNS event, so therefore headache will always be mentioned by the patients. Urinary incontinence is a feature which is again seen in both of them. The objective of discussion is to tell you, because the question will say that all of the features can be used to differentiate between the two, except please understand that in vasovagal syncope, when it comes to loss of consciousness in a patient, it will always be a gradual onset loss of consciousness, because as the blood supply to brain will decrease, there would be tunneling of the vision of the patient. Like this, if I take this circle to be the field of vision, there would be concentric shrinkage of the field of vision, and then the person will lose consciousness. Whereas in GTCS, it is usually sudden. Now this is also very subjective. So I am, as a doctor, looking for something which will tell me, okay, this is vasovagal syncope, this is GTCS. What is that? That is recovery. Apart from the tongue bite part, recovery would let me know between vasovagal syncope and GTCS, because recovery in vasovagal syncope is very fast. It occurs in a matter of seconds and can be rather accentuated by leg raise of the patient, because the moment you raise the leg, the venous return to the heart will increase, person will regain consciousness. In generalized tonic-clonic seizure, it might take hours. The person might keep on sleeping for very long duration, then might wake up, in a dizzy, confused state. He might ask you, where am I, and who brought me here, and questions like these. So clinically, how will I differentiate between unconscious patient of vasovagal syncope and GTCS? Recovery can tell me, tongue bite can tell me, and so does association of headache. But the remaining factors, because they're common between the two, so they do not usually help in identifying the manifestations in the patient. And if you are in doubt, if you are clinically not able to be sure, then one backup that you have is to run serum prolactin levels. And you will always notice that serum prolactin levels are always increased post GTCS in a patient, whereas they are usually normal after vasovagal syncope in a patient. So differentiation is definitely possible between the two. At this moment, I have explained to you aspects related to GTCS, where you will be noticing diffuse abnormal electrical activity in all the electrodes, versus focal seizures, where only in some of the leads you will be noticing this abnormal high voltage burst against a background rhythm. So you can easily differentiate between EEG of a focal seizure versus that of generalized tonic-clonic seizure. But this EEG should be recorded actually when the episode is occurring or immediately post the episode. If you are gonna do a EEG in the interictal period, that is episode occurred 2 months back and you are doing EEG today, there is a possibility that EEG can be normal. So lots of time in your OPDs, EEG would be normal, especially in focal seizure patient in interictal period, because at that time there is no abnormal electrical activity in the brain. For the sake of record, I would also like to say that today I have explained to you focal seizures that occur with impaired consciousness or with intact awareness in a patient. And then when it comes to generalized onset seizures, there could be various subtypes ranging from absence seizure having a 3 per second spike and slow wave pattern, atypical absence with 2.5 Hz pattern, atonic seizures where there will be decrease in the muscle tone causing a fall, but there will be no post-ictal deficit occurring in a patient, myoclonic, and then GTCS. We shall now learn regarding a couple of epilepsy syndromes. Let us recall the definition of epilepsy also. It is more than 2 episodes of unprovoked seizures in a patient. Provoked would be like in hypoglycemia, hyponatremia, unprovoked seizures. The first on the agenda is a multifactorial condition by the name of Lennox-Gastaut syndrome, LGS. Why it is asked is because there would be 3 kinds of seizures in a single patient. Like this person wakes up with GTCS in the morning. In the afternoon hours, the same patient could be having atypical absence, in which there would be a vacant staring spell, blinking of the eyes, and then the child will start behaving as if everything is normal. There would be a EEG discharge of 2.5 Hz demonstrated in an atypical absence attack. The third seizure in this patient would be atonic seizure, which would be having a sudden decrease of muscle tone, especially the neck muscles, and there would be head flopping or head nodding that would be seen. The etiology behind development of Lennox-Gastaut syndrome is multifactorial. We usually try to go for monotherapy in these patients. The drug of choice for Lennox-Gastaut syndrome is sodium valproate, and the EEG pattern that is seen in these patients is less than 2.5 hertz spike and slow wave pattern. The drug of choice for this condition is sodium valproate. If required, we can add additional drugs also, but usually in epilepsy world we try to prefer monotherapy for our patients. I will now be comparing Lennox-Gastaut syndrome with the second epilepsy syndrome that is called as Jan's syndrome. That's a slightly classical name that you have to remember. The easier name for the same is JME, juvenile myoclonic epilepsy. We first have to understand why it occurs. So this has a polygenetic inheritance. Unlike the previous one, that is Lennox-Gastaut, which was answered as multifactorial, here you will answer it as polygenetic modality of inheritance. Now let us see what is the problem. This will be a child 10 to 19 years of age. The mother thinks that he is deliberately getting late for school by spilling the breakfast on the dining table or onto his school dress. The mother will say that she is noticing that her child in the morning hours only, because she thinks she is doing it deliberately. So she says in the morning hours, there is involuntary movement, a jerky movement in the hands, or he's very clumsy, he's very careless, he spills milk on the dining table or onto his clothes in the morning and have to change his dress. By that time the school bus will leave, so it's off for school today. He does it deliberately. What she's not realizing is that the child is having an abnormal brain development due to genetic reasons, due to which he's having these abnormal jerks, especially in the early morning hours. Parents initially will not believe what you say, that this child is having a brain defect due to which this is happening. So to take their confidence and to be 100% sure that you are right of this so-called clumsy child who spills his breakfast again and again, you do a EEG. It's advisable to do a sleep EEG in the child. Like we'll admit the child is early morning, like 5 a.m., 6 a.m. There's a possibility that these myoclonic jerks will start. So the background EEG of this patient might be, let me say, there's sawtooth waves and beta waves which are coming up. So this child is now in REM sleep. It is 5 a.m. in the morning. He is dreaming. He usually gets up at 5:36 to get ready for school, rush to work. And now you will be noticing that in the EEG of the same child, some abnormal electrical bursts are occurring. So when you will zoom in and scan the data by second, because in EEG you can now identify the data or store the data on the hard drive of the computer, you can zoom in, zoom out. So when you scan the data for every 1 second, you will notice that there will be approximately only 4 to 6 waves. And each of the waves that are shown here will be having a different amplitude from the one that I've shown previously. So this is called as 4 to 6 Hz polyspike pattern and is again easy to identify on EEG. In an image-based question, maybe they may not give you a close view to identify that, but still, because nowadays we have these automated systems which can give you the discharge frequency. So the clinical part is important in this question, where the patient would be having myoclonic jerks, especially in the early morning hours, and this 4 to 6 Hz polyspike pattern will help you in identifying and telling the parents that I have bad news for you. The mother says, what can be bad than this? You will tell her that in future your child will develop GTCS. This is itself a question. What is the presentation of Jan's syndrome? It is myoclonic jerks. What is the future presentation? There is GTCS. And in fact, in about 30% of these patients, they will also develop a typical absence seizures also. That is the one with repeated blinking of the eyes, and the child becomes absent-minded. He stops answering your questions and then starts talking to you as if nothing has happened. There's no post-ictal deficit in absence seizure, as I've explained to you. So these manifestations can develop in future. Therefore, patients of juvenile myoclonic epilepsy usually will require lifelong valproate. I have not talked about the drugs initially for focal seizure and GTCS. I'll do that separately because that's a relatively long topic. But then for these easy syndromes, it's right now that I'm discussing the drug part of Jan's syndrome. Before you and prior to that, the Lennox-Gastaut syndrome also, first line drug is sodium valproate, because the major epilepsy found there is again GTCS. The myoclonus word will come again and again in majority of questions that you will attempt. So I'm talking about abnormal myoclonus now. As I've explained to you, it can occur in us at the initiation of sleep. But when are you gonna get myoclonus written in a question and you know that there is something wrong in the MCQ is what I describe you next. So be very careful for the subsequent information. Myoclonus can be described in a child less than 1 year of age with respect to a disease that is called as infantile spasms, which is also called as Salam seizures, or is also called as West syndrome. In this case, one, there might be a epileptic spasm involving the trunk. So the trunk might be bent forward and there might be a jerky movement of the arm that might look like a salam. If the age of the child is given as 8 years and this is an unvaccinated child, the child never had measles vaccine administered, then this particular child can get infection from a slow virus disease that would be subacute sclerosing panencephalitis, which is a late complication of measles, and the parents never bothered ever to get a measles vaccine to the child. Between 10 to 19 years of age, the child is getting always late for school, early morning episodes are there, and he's also having GTCS episodes in between, that is juvenile myoclonic epilepsy. And if you read a question of a person who's about 30 years of age, he had consumed beef and now he is having two things. One, he is having myoclonic or myoclonic jerks, and second, he is also having dementia of the cortical variety. Normally we read about dementia and Alzheimer's disease. At 30 years of age, he is having dementia and myoclonus. Then you need to think in terms of VCJD, that is variant Creutzfeldt-Jakob disease. So here I've just given you a crude but highly effective method to solve questions related to myoclonus given to you based on age group. Obviously, EEG patterns will matter, and I'll incorporate the EEG patterns as we'll progress in our discussion further. Like I will discuss EEG of variant Creutzfeldt-Jakob disease, subacute sclerosing panencephalitis also. Juvenile myoclonic epilepsy I've already talked about, so I'll just write that down. This would be 4 to 6 hertz polyspike pattern. The EEG of infantile spasm has also been mentioned, that is called as hips arrhythmia. I had explained that in hips arrhythmia there is no pattern. I mean, any wave can occur at any point of time, and there is a background suppression of the activity also, that is an electrodecremental response. So 2 EEGs have been discussed, 2 are still in pending, but myoclonus as a word is highly important for questions. That is why I have explained this aspect before you. And I would also like to go back in the slide to remind you that I am teaching you epilepsy syndrome. The 2 have been discussed, Lennox-Gastaut and Giant syndrome, that is juvenile myoclonic epilepsy. I'll be now explaining the third one to you. This is asked because the question will begin by saying which of the following epilepsy syndromes will not respond to medication or will be medically refractory / which of the following epilepsy syndromes is amenable to surgery. The answer will be the topic we are studying, MTLE, mesial temporal lobe epilepsy. The highlight of this particular disease would be a MRI head which shows presence of hippocampal sclerosis. In fact, this information may not be given right in the starting of the question. He might describe that this person, when he was a child, there was a history of febrile convulsions. Every time this child used to become sick, especially associated with fever, there used to be development of febrile convulsions. Now when this person is grown up, there is development of focal seizures with impaired awareness. He started writing this long terminology. The examiner might even use a short version, that is automatism. I've explained to you that automatism means uncontrollable laughing, crying, lip smacking, chewing movements, swallowing movements by a person. So when you read a history like this, you will be performing a EEG in the patient that will be showing abnormal electrical activity over the temporal lobes. It could be unilateral or bilateral depending upon whichever side the sclerosis is present. So whenever you read temporal activity or temporal spikes present in a patient, which could be unilateral, bilateral, you will now do a MRI head in the patient, that is hippocampal sclerosis. If this word is given, the diagnosis straight away made. Even if it is not given the way the clinical history is given, you would be able to identify the condition. The drug of choice for all the epilepsy syndromes that I have described to you is sodium valproate, because this has a good, I would say, range of action over all these abnormalities in the brain, and even the safety profile of sodium valproate is fairly good. So we use it as a frontline drug for all the epilepsy syndromes or most of the epilepsy syndromes. And ultimately, because anyway this person will not respond to this medication on the long-term basis, if I want a good prognosis, if I want a good control, I will prefer surgery for these patients. Please appreciate that whenever we give anti-epilepsy drug, we try to go up to the maximum dose of a single drug. Usually we don't try for polypharmacy, we don't try to combine 2 or 3 epilepsy drugs because the side effects tend to amplify. In this condition, you might have to give adjunctive drugs, you might use rufinamide, you might use supportive drugs in the patient, but the problem is how much of these drugs will you give, because the side effect part will keep on increasing. So we will motivate the family to give consent for the neurosurgical component of this patient. The treatment of choice for this particular condition is not drugs, but should be answered as surgical resection of the hippocampal sclerosis lesion. Obviously, that will have its own debilitation, but then the best that can be done for these patients or improving the quality of the life of this person is the aspects that I have said. For treatment of the various seizures that I have discussed before you, we will now draw a comprehensive list. I have today explained two types of seizures to you: focal seizures with intact awareness and then impaired awareness. For both of them, the first line drug to be used in the patient is carbamazepine. The drugs which are recommended for this patient in the current edition of Harrison are L2-COP. So I will just mention the names here. That is levetiracetam beginning with L. The second L would be for lamotrigine. C would be for carbamazepine. That's mentioned first actually in the book. Then oxcarbazepine and then phenytoin. Now, I would like to say that those MCQs of yesteryears like drug of choice, etc. have become a little outdated because they're giving proper clinical based scenario. So if they mention in the exam that there is an elderly patient who's having focal seizures and what is the drug that is recommended, then the answer is levetiracetam. Why? Because levetiracetam has the least amount of drug interactions with other drugs. Not only this drug has less interaction with other anti-epilepsy drugs, but in old age the person might be on medication for diabetes, medication for statins, medications like statins or for heart disease. So this drug has less interaction with others, so therefore it is preferred. For lamotrigine, he has mentioned a word of caution. He has said it's a safe drug to be used in focal seizure, but the Stevens-Johnson syndrome risk should be kept in mind. So if a person is on lamotrigine, you have to keep a watch for development of any vesicobulbous lesions on the skin. If nothing is given in the question, the first answer will be given as carbamazepine. But he has also mentioned that people on carbamazepine can either be having a development of anemia, or could be having leukopenia, or could be having hepatotoxicity. He says that if a person is having any of these risk factors present in the form of decreased HB, TLC or hepatotoxicity due to alcohol, then change the answer to oxcarbazepine. So I repeat my statement. In Harrison, he has not mentioned one single drug as drug of choice. If nothing is given, I would like you to answer as carbamazepine. But if he's gonna start talking about specifics would mean like somebody is already having a liver damage. Then he says that don't give carbamazepine because it causes damage to liver. Then use a safer metabolite, that is oxcarbazepine in a patient. Phenytoin is given at the bottom. Why? Because it's a relatively old drug, and the problem with phenytoin is, as you know, the toxicity part can come up very fast. So therefore, we are more comfortable using the drug superiorly. That is for elderly patients. Answer is levetiracetam. If nothing is given in the question, carbamazepine. If liver is damaged in a patient, it is oxcarbazepine. Let us now take up the case of generalized seizures, GTCS. The first line drug to be used for these patients is sodium valproate. However, in female patients, it can cause problems because this is a highly teratogenic molecule. So one, he has now mentioned that for generalized seizures in a female of reproductive age group, one should not start with valproate but should start with levetiracetam. He has first mentioned levetiracetam and then mentioned lamotrigine. And this was asked in one of the recent exams also, that which of the following epilepsy drugs has been documented to have least teratogenicity. Please do not be under impression that levetiracetam and lamotrigine will not contribute to neural tube defects. All of them can contribute to neural tube defects because all anti-epilepsy drugs cause folic acid deficiency. It is just based on percentage. Valproate is highly teratogenic, levetiracetam is least teratogenic. So even when you are writing these drugs to a pregnant lady, don't tell her or give her an impression that oh, neural tube defect will not develop, because if she's on levetiracetam and she conceives, there is still a possibility of entity in a patient. The language of the question will be which of the following molecules is the safest anti-epileptic drug in a female patient who wants to conceive also. Please appreciate the fact that if she has already conceived, there is no point of changing the drug. Suppose she is on valproate, she came to you in second trimester, no point of changing the drug because organogenesis occurs in first trimester. She has come to you in the second trimester, third trimester, there is no point of changing the drug. But yeah, if in the same patient, if she says I'm gonna be married next month or next to next month, you have put her on lamotrigine or levetiracetam, either of the two at the moment, then the chances of neural tube defects will substantially or significantly be reduced. So if he asks you what is the drug that is recommended or first line drugs for generalized seizures, the answer is L2V. L2V would mean stand for L for levetiracetam, lamotrigine and valproate in a patient. And I would like to put it like this, that currently they are not using the word drug of choice, but they're using first line drugs. So they will give you a list of drugs and you will have to select, because most of the questions that are coming are of multiple select options. So if you are asking me a question, what is the drug of choice for one particular seizure disorder in Harrison, there is nothing given like this. In fact, in no book it is written like this. It is just given first line drugs to be given to a particular seizure disorder. So this is the list that I wanted to remember. So let us finally summarize the drugs which are recommended for the various types of seizure disorders. This table that I'm discussing before you is from the 20th edition of Harrison. There is a possibility that some of this information might be different from that of pharmacology. I'm open to debate, but this is what Harrison says, so I would recommend you to answer it according to the way that I'm telling you. We will have to remember information for atypical absence, atonic seizures and myoclonic seizures. Let us revise this information. I'll start from the right hand side because more data there. You can remember three names there, that is VLT. For first line drug to be used for any of the three, it is valproate, then is lamotrigine and then is topiramate. This is directly from the 20th edition of Harrison. So if you are finding some difference from pharmacology, I'm okay with it. I'm ready for debate. Do send me a difference, send me a question across. But I would recommend you still, and I'm saying it for second time, to remember this information only. For then, I would like you to remember VLE for first line drugs. Do remember that in no book is written drug of choice. That's a very myopic question. It is valproate that is same, lamotrigine that is same, but E here would stand for ethosuximide. I have explained to you that valproate, if given to less than 2 years of age, hepatotoxicity component comes up. For focal seizures, it is L2-COP. L2 means lamotrigine as well as levetiracetam, then carbamazepine, oxcarbazepine and phenytoin, as I've explained to you. In GTCS, he has written lamotrigine in the table first, then is written valproate. In the theory is written first valproate, then lamotrigine. Doesn't matter because now we are not calling them drug of choice, we are calling them first line drugs. And the third drug that he has also mentioned for GTCS is levetiracetam. This is a final table that I would like you to remember for the topic of seizures. Over and above this, if they ask you how do you manage febrile seizures, though this is bit of pediatrics. For prevention of a febrile seizure and treatment of febrile seizure, the answers are different. If he specifies the word prevention of an episode of febrile seizure, then we will be giving oral clobazam in intermittent prophylaxis. I mean, as long as the child is having fever, he will be on oral diazepam or clobazam to prevent the episode of seizure. If there is an episode occurring, there are two ways to manage it. One is the conventional method, that is give rectal diazepam to the child. But this is very cumbersome, and I think you would all agree that if you tell an educated lady put something in the anus of the child when he's having fever, she may not agree to it and she may not be very comfortable. So what you will do is you can use and ask her to purchase a 400 rupees bottle of midazolam. You can give midazolam one of in each nostril, and it is very easy to give also. Like this mother is a working mother, child is with a grandmother, and grandmother is not so educated. She is like 70 years of age herself. She has difficulty walking. How do you think that she will take care of the child? But if you explain to this grandmother that you have to insert, just in the tip of the nostril a medicine and just give a spray, she might still be able to handle the child when the mother is away at work. So intranasal midazolam and rectal diazepam are used for treatment of an episode of febrile seizure, and for prevention it is oral clobazam, if not given oral diazepam. Pharmacologists will mainly say rectal diazepam because that is what is given, but ideally it is recommended to answer as intranasal midazolam for the patient. One more aspect on this slide that will be added on the top would be for infantile spasm. The drug of choice would be answered as ACTH injections. However, if infantile spasm is given in combination with a neurocutaneous disorder, that is tuberous sclerosis, so I'm just gonna write in bracket here TS. TS would mean there is tuberous sclerosis present in a patient. Then the drug of choice for the patient will change due to slight less space, but I think I can just squeeze it in. For infantile spasm, if they ask you, the drug of choice with tuberous sclerosis should be answered as vigabatrin. This is a list of various drugs which are used in various epileptic disorders that I have described before you. From pediatrics perspective, do remember the fact that if they ask you which is the most common type of epilepsy in children, do not answer subtle seizure. That is the commonest one in newborn babies, and that is a seizure. It is not an epilepsy. The question was, what is the most common epilepsy in children? You can read more about in pediatrics. That is benign Rolandic epilepsy. Well, what is it? It is a presentation of focal seizures only. The peak age of onset of benign Rolandic epilepsy is between 2 to 13 years of age. The child will be sleeping, and on the one side of the face there was involuntary twitching or involuntary contractions which the mother noticed and brought the child to you. You did a EEG and then did a MRI and or a CT head, and finally you prescribed carbamazepine for the child, because in children, if they're having focal seizures, you have to rule out any local focal lesion also. So I did a CT head or MRI head, and then carbamazepine has been started in this child, and gradually the episodes will reduce as the child becomes a teenager. However, if he says what is the most common type of seizures in a child, then the answer should be given as febrile seizures. If he says what is the most common subtype of seizures in a newborn baby, then the answer is subtle seizure. Subtle basically means mild manifestations. So here the pediatrician might even say the word jitteriness. Jitteriness would mean that the child might be having tremors of his lips, tremors of his fingers, because children don't have a proper GTCS because their CNS is not fully developed. So most of the time you would be having tremors. The tremors would be in the lips of the child, hands of the child, or there might be cycling movements with the child, kicking movements with the child, like child is lying and he's kicking, or there's like boxing movements with the child. So parents might be very amused seeing the child doing this boxing movement, leg movement, but it is grossly abnormal. Then a question came, what is the cause of subtle seizure? A lot of people left that question. The cause of subtle seizure is birth asphyxia. The number one cause is birth asphyxia, then is metabolic problems like hypoglycemia, hypocalcemia. But birth asphyxia is responsible for majority of cases of subtle seizures. These are three questions from the pediatric domain that I also wanted to remember. And West syndrome, infantile spasm, they all mean the same. The highlight of the EEG was hips arrhythmia. We can also use this opportunity to practice the theory aspect for the various EEGs that I have explained to you. There are certain numbers which are worth remembering. If he says less than 3 Hz spike and slow wave, that's the easiest one for anybody. Absence seizure. But if he says less than 2.5 Hz spike and slow wave pattern, then it means that the patient is having an atypical absence seizure which is associated with Lennox-Gastaut syndrome. If it is 4 to 6 Hz polyspike pattern, then it is juvenile myoclonic epilepsy. We'll just mention the names here for the 3 EEG number-based data that I've explained to you. The drug of choice for absence seizure and atypical absence still remains sodium valproate. It is just that atypical absence will be relatively more longer duration. Lennox-Gastaut syndrome can also be written in the question here because atypical absence is associated. JME is juvenile myoclonic epilepsy, where the child was having involuntary movements in his hands. He was spilling his breakfast again and again, so mother was saying that he is doing it deliberately. That would be called as Janz syndrome. Then I want to bring to your notice a very peculiar EEG in which there will be high voltage bursts present every few seconds. You will notice that these bursts will be going in upward direction only. Contrast this with another one that I draw before you. In which you will notice variable amplitude bursts occurring in a downward direction. The first one, you will notice that there will be a periodicity, that after every few seconds these high voltage bursts are present, So we call them periodic sharp wave complexes. They're called as PSWC. They are basically noticed in patients who are having a neurodegenerative disorder called as variant Creutzfeldt-Jakob disease. This person has consumed beef of poor quality. The cow was having a disease that is mad cow disease or bovine spongic encephalopathy, and the piran particles which go in the body along with beef, and they're not killed by heat because they are resistant to heat, rather piran particles. So once they go in the body of the person, they cross the blood-brain barrier, they go into the neurons, they multiply in the cytoplasm neurons, and they will cause this abnormal electrical activity, that is periodic sharp wave complexes. And every time there is a periodic sharp wave complex, it will correspond to myoclonus. So the clinical history of variant Creutzfeldt-Jakob disease would be beef given in the question. Even if it is not given, he will talk about myoclonic jerks in a chap with dementia. This is a combination that you need to remember. Like, you know that dementia plus chorea is Huntington's chorea. Similarly, I want you to remember myoclonic jerks plus dementia would be called as variant Creutzfeldt-Jakob disease, that is periodic sharp wave complexes. Now, if you look at the next EEG that I've shown before you, one, you will notice that there is no periodicity. I mean, they're not occurring at regular intervals, and even the amplitude or the depth of these is also different. Well, these waves that I've shown before you are also having one more peculiar feature. In EEG, everything that goes up is taken to be negative, and everything that comes down is positive. Normally it is opposite, no? Everything that goes up is positive, down is negative. In EEG, going up is negative, downward is positive. You are noticing here a wave that I've shown you, which is preceded. You can see before this positive wave is coming, before this there is a negative wave, after it is also a negative wave. The characteristic name of this wave, which is very deep, it goes in like a deep spike, and then there's a preceding negative wave and a following negative wave, is technically called as triphasic waves. Triphasic waves are found in metabolic encephalopathy. There is a generalized slowing in the EEG of the patient because ammonia intoxication is what we are talking about, and you will be having these characteristic waves that are called as triphasic waves. So these are some of the name-based EEG patterns that I would like you to practice and remember, and I'm sure that if they give you this kind of a data, you will score over other people. So once we have practiced this patterns in theory, let's do some image-based questions that will make or increase our comfort level in questions. These are very standard images in Harrison, and most of the time if they're gonna give an image, they have given it from Harrison only, so it's a good idea to actually practice these. In the first one, you will notice that in all the leads, you can see the left one as well as the right side. The left is odd and the even one is right, as I've explained to you. You will be noticing these spikes present, and they are occurring at a rate of about 3 per second. So this pattern is suggestive of absent seizures in a patient. On the other hand, if you look at the EEG below this, which I've shown already, in all the leads, there's a diffuse pattern that is showing abnormal spikes, which would be GTCS. But then you will notice that you can see abnormal discharges only in the temporal leads of the patient, so we will call it focal seizures in a patient. On the upper right hand corner, you will notice a EEG which is very asymmetric. This pattern is called as hypsarrhythmia. The first time you read it, it looks like a ECG finding, but as I've told you, this is a feature of infantile spasm or epileptic spasms. Infantile spasm is also called as West syndrome, or is also called as Salam syndrome or Salam seizures. So all these terminologies, they basically mean the same. There are three for the same thing: infantile spasm, Salam seizure, and West syndrome. I've already explained to you the treatment is very atypical, ACTH injections, and if it is with tuberous sclerosis, vigabatrin to be answered. Now comes slightly two difficult ones, and we'll try to knock some sense into these. One, if you look at the one on the right hand side, you will notice that these waves that are coming are still occurring on a fairly irregular basis. So because they are pointed and they're occurring at a regular basis, I'm going to call them periodic. Pointed, so sharp wave complexes. PSWC is both a theory question as well as an image-based question for you. This is a feature of variant Creutzfeldt-Jakob disease. And similar kind of impulses might even be seen in a neurodegenerative disorder in pediatrics by the name of subacute sclerosing panencephalitis. In contrast, if you look at the one on the left hand side, you will notice this wave that is going like this downwards, that is positive, and it is preceded by positive waves. It is preceded and followed by positive waves. So you can see two positive waves and one negative wave then going down. This is what is technically called as triphasic waves. This is a feature which is very characteristic of hepatic encephalopathy. If you get these rhythms in the exam, I want you to nail the question right in the first row. So try to get a visual impression, as I've highlighted multiple times. A doctor is supposed to have a photographic memory. So if you can just remember these 6 images that I've shown to you in a photographic, I would say, snapshot into your brain, then I'm very sure that you would be able to overscore over your rivals who may be actually missing out on this information. This is a table from Harrison that I have just included in the discussion just to show that why have I talked about all these drugs. Like you can see that lamotrigine and levetiracetam both are mentioned. In old age I talked about levetiracetam for focal seizure. Though in pharmacology they will simply say carbamazepine as drug of choice, but these alternative allied aspects that I've explained to you should also be remembered. This is courtesy Harrison. The next that I'll explain to you is a condition whose EEG pattern will be identical to that of variant Creutzfeldt-Jakob disease, that is periodic high voltage discharges. The condition is called as subacute sclerosing panencephalitis. This is a late complication of measles. This child is living in an area where the coverage with measles vaccine is very poor. Therefore, this child has suffered from an attack of measles. He's having clinical features of measles, that's a maculopapular rash all over his body. But luckily, his immune system has reacted and therefore the rash of measles has disappeared. After 2 weeks, all the features of measles have disappeared. Normally, after measles, we have complications like otitis media, pneumonia. Here, not even those complications have been seen. So the good news is that his immune system has responded to measles and there is no clinical manifestations. But unfortunately, the virus that he got infected with is a mutated, altered measles virus. We have documented nowadays that in areas with low vaccine coverage with measles, the measles virus tends to mutate and gets converted into an altered measles virus, which can avoid the security system of the body. The clinical features of rash will disappear, no problems with that. But the virus develops the ability to avoid the security system in a sense that it crosses the blood-brain barrier and goes in the neurons and starts multiplying in the neurons. It will take a very long time for the virus to live here and keep on multiplying in the neurons of the child. So the same patient at 8 years of age will start developing manifestations of subacute sclerosing panencephalitis. Mark my words here. This child lives in a low vaccine coverage area. Measles vaccine was not given. He suffered from measles at 2 years. But the clinical features of subacute sclerosing panencephalitis will develop as late as 8 years of age. So it will take 6 years for the virus to cause sufficient damage enough to cause manifestations. This is also casually called as slow virus manifestations or slow virus disease. The manifestations of the child will be myoclonic jerks. The involuntary movements are being noticed by the teacher as well as by the parents. Earlier, this child used to go to a government school in the village. He was a brilliant child. He used to love studying. But now the teacher is saying that he does not pay attention in a sense that he is not able to solve any basic mathematical problem. He is not interested in his studies. His scholastic performance is decreasing. So the mother thought that maybe the child doesn't want to study anymore and they brought him home. And normally this child was like, very affectionate to the mother. He used to, he was, let me say, the youngest in the family, was very close to mother or father. Now this child is not showing the affection to parents. Why? Because in this condition, there would be a development of apathy in the child. There would be lack of interest in playing with friends. There would be lack of interest in playing with toys. Like in a village, I'm not saying that there would be television available greatly or like this child is having a favorite cartoon character and things like that. But at least the child would be, playing around with the children of his same age, would be interacting with his mom and dad. This child is having apathy to the level that he's lying in the bed in the morning, staring at the ceiling, staring at the wall. He's not responding to parents. Not that he cannot speak, but later on even the speech will get compromised in the patient. The virus is gradually multiplying in the neurons, destroying the neurons in the brain. So this child will become totally bedridden. He will be urinating and defecating in the bed. Earlier, see, 8-year-old child can get up and go to the bathroom in the morning by himself. This child will be lying in the bed. There would be urinary incontinence. There would be a stool incontinence developing in a child. And finally, this child will expire. There is no treatment for subacute sclerosing panencephalitis, though there are drugs that are being used currently, but I would say the availability of those drugs is a problem, and most of them are mentioned in research articles as compared to, I would say, a traditional textbook. Now, how do we diagnose a subacute sclerosing panencephalitis? It is either diagnosed by brain biopsy, but that would be post-mortem. Our role as a doctor is to identify it earlier. So how would you identify 8-year-old child with mental deterioration, which would be like myoclonic jerks developing in a child? EEG identical to that of variant Creutzfeldt-Jakob disease, and the main point in the MCQ would be CSF study, where you will be able to have two things: slightly elevated proteins and presence of antibodies to the measles virus. Mark my words there, measles virus antibody in the blood can occur in any patient who had a measles infection. Here the measles virus antibody is present in the CSF. That's the troublemaker. This slow virus actually has a tendency to avoid the security system by crossing the blood-brain barrier and going into the brain, and then hiding inside the neurons and avoiding the security system in the body, and meanwhile continues to eat away and destroy the neurons. So subacute sclerosing panencephalitis occurs due to altered measles virus. What I mean by altered measles virus is this is a mutated virus. It circulates in those communities where the coverage with the vaccine is relatively poor, and most of the time we see that this altered measles virus, its clinical presentation might be identical to that of standard measles only, but because it can avoid the security system, hoodwink the security system, damage to the brain is seen in these patients, and we can easily eradicate SSP from all those communities where the cases have come by simply increasing the vaccination drive in the community. If measles vaccine drive is proper, then the cases of SSP will stop coming. This is a late complication, neurological complication of measles. Early complication is pneumonia and otitis media, and mainly out of 5 points, 3 points are a must know for you. I'll repeat again: neurodegeneration with myoclonic jerks, presence of high voltage burst in a patient, and presence simultaneously of this antibodies against measles virus in the CSF is the main diagnostic feature for this condition. Lastly, I would like to mention regarding a neurocutaneous disorder which has been extensively asked and is called as tuberous sclerosis. This would be related to genes TSC1 and TSC2 gene. TSC1 is related to 9 chromosome, TSC2 gene is related to chromosome number 16. In these patients, the cutaneous manifestations are very classical, and I'll just show them to you. In a butterfly distribution, mark my words, they're not saying butterfly rash. In butterfly distribution, you would be able to see these acneiform lesions. This is referred as adenoma sebaceum. This is very characteristic manifestation of this patient. The second one is over the skin of this person, you will be able to notice this irregular appearance of the skin that is called as Chagrin's patch. Third, if you look at the nail of the patient, there is a fleshy growth occurring here. This is called as subungual fibroma. This is also called as Coinen tumor. These are the cutaneous manifestations that are occurring in this patient. The earliest cutaneous manifestation in tuberous sclerosis, however, would be presence of ash leaf macules. On the skin of an Indian patient, you would be able to easily notice, because we Indians are relatively dark skinned, so the child will be having presence of these hypopigmented macules. These hypopigmented macules are usually encountered on the trunk of the child. This would be the earliest cutaneous marker. Now, why we are studying this is because in these children, there will always be a family history of epilepsy, like the father and son both are epileptic and both will be having same skin manifestations and are neurological manifestations. What are the neurological manifestations of the patient? In the first year of life, this child will be having a tendency to develop infantile spasm. And from the next year onwards, the child would be having focal seizures. For infantile spasm, we will use vigabatrin for the patient. For focal seizures, we will be using carbamazepine in the patient. Because from a very young age, this child will be having requirement of anti-epilepsy drugs, so side effects of them can also be noticed. This is basically a condition in which you will be having both father and son, father and daughter, having same problems of skin as well as neurological manifestations of seizures right since birth. Because the problems are occurring since birth, mental retardation will also be a feature. If you will do a CT head in these patients or a MRI head in these patients, you will be able to notice these lesions, which might initially look like neurocysticercosis to you, but these lesions will mainly be present periventricular, just outside the ventricles. You see, neurocysticercosis lesions would be present all over in the cortex, but you will notice these lesions are present related to the temporal horns of the ventricles or adjacent to the ventricles. These periventricular lesions that are present here are called as SEA, that is subependymal astrocytoma. This is a malformation in the brain which is responsible for epilepsy in this patient right from a very young age. The CNS malformation is subependymal astrocytoma. Another aspect to be remembered for these condition or this condition is related to a very peculiar lesion in the kidney that is called as angiomyolipoma. That you can see a lesion in the kidney which is having three things together, that would be blood vessels plus muscles plus fat, and then they could be bleeding in this angiomyolipoma also, that would be referred as Wunderlich syndrome. So very peculiar terminology is here. Why we have discussed is because in this condition there would be genetic basis for epilepsy to be present in a family. The question asked in the exam was father and son both are epileptic, both were, and in image based question father and son close up was given for adenoma sevicium, and he said what is the disorder that could be present. The answer is straightforward, tuberous sclerosis. Then another neurocutaneous disorder towards the end that I would like you to remember is called as Sturge-Weber syndrome. The highlight of this disease, which is again a neurocutaneous disorder, would be presence of a CNS malformation. You can see on these patients there would be a port wine stain present. On the same side of the face where the port wine stain is present, there will be a same-sided cavernous angioma in the brain. Please note that the topic is neurocutaneous disorder, which is responsible for epilepsy. So the cutaneous is port wine stain and the neurological is cavernous angioma. The manifestations can be remembered like this. The patient will be having recurrent episodes of focal seizures because there is a CNS malformation. Alphabet T would stand for trigeminal nerve distribution, would be having this port wine stain present. U stands for unilateral weakness, that is explained by the cavernous angioma component, which can press on the corticospinal pathway causing upper motor neuron signs in the patient. R stands for mental retardation. Both tuberous sclerosis and Sturge-Weber will be having mental retardation. G and E stands for eye manifestations of the patient, that is glaucoma, and the E component, the eye manifestation that is encountered in these patients, would also be written as buphthalmos. I have just taught you a shortcut to remember Sturge, S-T-U-R-G-E. That would, R is for mental retardation here. This is again a neurocutaneous disorder, and if you do a CT head in these patients, you will be having a visible calcification in the brain. This is called as tram track appearance. So two very peculiar CTs have been shown to you, one having a subependymal astrocytoma, second having a tram track appearance, and they are responsible for a hereditary basis of epilepsy. Both of these are two important topics which I want you to remember. The terms used to describe these disorders are phacomatosis / neurocutaneous disorders. I would suggest you to read about these even from pediatrics so that you can have a better insight. So when you are done with the topic of epilepsy from this, I would like you to also do the same topic in pediatrics as well, so that you're done and dusted with these questions. Believe me, these questions are very scoring. The epilepsy component is very straightforward. I might have eaten a little bit of extra time of yours, but I'll be very sure that if you invest your time into EEG, you will be able to score over others, and it is very simple. You see all these graphs, etc. We as doctors are mainly afraid of mathematics or paranoid about mathematics, because that's why we took up biology. Let's be frank. So all these graphs, etc., they look very dominating to us. Rather it is one of the easiest thing. You will see technicians interpreting EEG. You will see technicians interpreting ECG better than most final year doctors or maybe interns. Why? Because they say it daily. There is no big deal about interpreting a ECG or a EEG. It may look like that to you at the moment. If you're listening to me, you might be thinking, what am I talking? Believe me, these technicians, they're doing a better job simply because they're doing it on a regular basis. Now, if you are seeing a MI Delhi in the casualty, every time you see ST elevation, you get used to it. It's a second nature for you. So don't try to do ECG, EEG questions in one go. If you are gonna do it like in one day, I'm gonna finish everything, not possible. ECG and EEG, my only advice is do 2 every day, but do every day for next 5 days, 6 days. Then you will start getting the subtle parts, and try to do it in the early part of the morning when you're relatively fresh, not when you're tired, because most of the time, to analyze all these data, you need a fresh mind, thought process. So if you start doing this 2, 3 every day, it will keep on accumulating, and make a habit of noting down also. Please note down, please appreciate my words. Audio stimulus, visual stimulus, and tactile stimulus. There are 3 stimulus, so your ability to retain will be more. So though these apps, etc., are providing you with handwritten notes, that inculcates what laziness, I would say. Once you're lazy, notes are there, everything I am speaking is present in the form of notes. I mean, you are just passively listening to me. In between there's a WhatsApp notification, you're checking it out. So another advice that I want to give you: do not keep any social media on the app or on the iPad that you're using at the moment, because if you keep on getting notifications, you are bound to get distracted. Believe me guys, there's a war out here, it's competitive, every day things are becoming difficult. So I would like you to be all pumped up and going for the kill, go for the jugular, as I would say. But then, it's knowledge that will build up your wiseness. Knowledge is power, as I've always said, and I'm finishing this lecture by saying knowledge is power. Keep learning every day. Thank you all for having your patience, for listening me out that long. Thank you.